lalui sentinel node biopsy ni. Sentinel node procedure lah. Biopsy ni macam ngambil isi untuk tahu kan apa. Clinically no palpable nodes. Mana sini? Imaging pun node negatif. Maksudnya imaging tadi Dr. Lau dah buat scan. Tak ada pun yang dia tunjuk yang apa nama tadi, lymph node yang leper dengan cortex yang nipis dengan fatty hilum masih tebal. Normal. Kita rasa pun normal. Kalau patient dah has undergone staging CT pun tak nampak enhancing. So okay, N0 in all dimension. Ataupun imaging suspicious nodes ada, tapi dah buat FNA ataupun TrueCut, bukan CA. Actually is maybe patient pernah buat vaccination recently. So you can proceed with sentinel node biopsy, and usually the tumor is T1 T2 lesion. T1 is less than 2, T2 is 2 to 5. Tapi usually we go up until 4 cm sebab tumor size is directly proportional to node involvement. Lagi besar tumor, lagi most likely the axilla is affected. Okay. But if you, kalau you read down to yang Z11 study tu, ada tumor dia sampai yang 7 cm pun. But I think yang tu yang, yalah, you look lah into it. Okay, so dah habislah cerita mukadimah tadi tu. This is where is my talk going to start actually. How do we do it? The indication dah clear tadi kan. OT list. Kalau ada kita punya MAT and nurses, nampak, doktor ni letak OT list dekat bawah pukul 4. Kena letak first or second in the list. Sebab panjang lagi prosedur. It's just not taking it out. Available or not technician masa tu, sebab saya selalu tanya dia orang, bila technician ada, it's not available every day 24/7 365 days a year. So kena tanya dulu availability of pathologist also. Boleh tak buat frozen section? So tak ada yang available. So find out first. And not the first day of the week, sebab our protocol here is 1 day protocol, not same day protocol. So they inject technician 1 day before, and the next day can only we do the surgery. So tak nak dia orang datang hari Sabtu kan, just to inject your technician. But some hospital do same day protocol. Maksudnya dia inject pagi tu, kita dah try dulu, dia orang dah try, and semua list spesifiti hari tu tergendala. Sorry. So sekarang ni they meet in the middle where they do 1 day before, but they stay until 5 something kan, just to get everything in order before they go home. And not suitable for 2 consecutive cases. Kita pernah buat, semua ni kita dah buat lah, try and error. Mungkin di tempat lain they can, but because sometimes by the time in the afternoon tu your technician degrade even further, susah nak buat kan hari tu kan. And then kita punya pathologist pun dah penat, wear off dah. Alahai. Satu lagi, frozen is not a simple procedure. Pre-operative day, patient will go to nuclear suite. So communicate lah with the nuclear physician. Jangan tahu-tahu besok pagi, mana lymph node saya? Jangan macam tu ya. We start communicate with the nuclear physician. I always know the lymph node already before, so besok pagi tak adalah alamak jauhnya lymph node ni So you must find out where is the node, because dulu macam ni je gambar dia. And then they will put an X mark on the skin, so you tak tahu how deep is it from the skin. But now they have SPECT CT, boleh tengok from all dimension. Tengok coronal, tengok sagittal, tengok axial. Where is it from the skin? Ni jauhnya daripada skin ni This is the node, this is the skin. And then this is the skin, this is the node, almost at the thoracic cage. So kita boleh agaklah besok pagi, lambatlah nak cari node. Boleh lah, pathologist tanya, pukul berapa nak hantar lymph node? Kita pun kata, okey lah, pukul 11 lah. Boleh lah dia pergi mana-mana, taklah dia tunggu. Mana lymph node ni, mana lymph node ni, tak sampai-sampai. So you've got an idea where your lymph node is. Operative day, this is a picture from internet. GY et al. Dia buat ni clinical utility of additional use of blue dye for ICG for sentinel node biopsy in breast cancer. Now ada lagi new way of finding the node with ICG. Patient is done under GA usually sebab it will be combined with operation for the breast as well. Breast either you nak buat mastectomy or white local excision is according to indication. Katalah kecil, buatlah multicentric, buatlah mastectomy. And position usually macam nak buat axillary dissection as well, because in case you have to proceed with axillary dissection, tak payahlah nak sibuk-sibuk betulkan balik kedudukan patient. So you cuci and drape macam cantik macam ni. Usually Dr. Azlina will mark already. Tadi kan ada gambar dia dah mark. And then they put a offside. So mark tu tak lari. Besok pagi kita buka mark tu, offside tu, mark tu pun ikut offside tu. Dah tak ada dah mark ke mana. Tak adalah. But usually adalah bekas-bekas dia, so kita mark balik. Check the count at the tumor site dengan kita punya gamma probe tu. And then tumor, kita tengok highest count at the tumor, note on the wall, and highest count on the skin, on the X mark, note on the wall, note on the whiteboard. And then I proceed with injection of 2cc 1:1 diluted 1% methylene blue dengan normal saline at the edge of this outer upper quadrant, here and here, dermal, subdermal. If it is on the left side, it's 1 to 2 o'clock, and on the right side is about 10 to 12 o'clock. About the area, 11 to 12 macam tu, 10 to 11, subdermal. And massage area of injection for 5 minutes. Because lymphatic is unidirectional. So dia akan pergilah. And at this time, sometimes if kita ada NS yang kadang-kadang put pectoral block kan, I cakap dengan dia don't put pectoral block pre-op lah. Because sometimes it will flood all the area, and the pressure from that interstitial local injection will prevent your movement of your blood, blue dye. Okay, this is your methylene blue. This is what we have in OT. Dulu kita pakai patent blue, but very difficult to get, and patient get anaphylactic. Ada, bukan not patient lah. There's history of anaphylaxis with patent blue, and very difficult to get actually. Dia kena ada import permit lah semua. And finding the sentinel node. This is our old gamma probe. Gamma probe ni was acquired during arwahnya Dr. Zainal Mahmud, our previous head of department. So I owe it to him that to use this for the first few, actually not the first few, the first almost 15 probably sentinel node biopsy. And then this is a new gamma probe. Gambar Yana kat sini keluar, sorry Yana. So okay. So after injection, you find your lymphatic channel. Locate the highest radiation count. You already inject the blue dye. You do skin incision. Usually skin incision is on top of your X mark. And then you find your blue channel. Macam ada fine like hair blue, because it's where your lymphatic channel is. Okay, and then you follow the channel until this. You dah buka tadi. You inject here. So by the time you buka ni, the channel will be starting going to the axilla. At the same time, you check the count. And then once check the counts, and you take out the lymph nodes, and then you check the count that lymph nodes. Okay or not okay? Kita orang buat itu last 3 weeks. Oh, very excited, lymph node dah keluar sekali. Count is about 900. Yang dalam tadi dalam 5,000 lah. So when we go back to the ni, ada lagi actually. That's what happened lah during the surgery. So check the count once excised, and check the cavity count once excised, and less than 10 initial count will be like there's no more nodes lah for you. And at the same time, you look for the blue node as well. Most of the time it's concur. The blue node will be the node with the highest count. But last time it's not actually. The highest count ada one speck of blue aja, belum sampai, because it's almost in the axilla itself. Anyway, after that, After removal, this period is the most important. Everybody from the start of your surgery will be in the same wavelength, saying that all the notes go to pathology. In the last 2 incidents, 2 notes dah pergi. Everybody is like waiting, languishing. Okay, waiting for. And I look at the cardiac table. Apa ni? Ada 2 note lagi tak pergi. So everybody must be in the same wavelength. Notes all go to frozen section. It will be labeled ABCD ke 1, 2, 3, 4 ke, up to you, and Sentinel 1, 2, 3, Sentinel first or second. And then waiting for frozen section to be ready, proceed with the breast surgery, white local or mastectomy as per indication. And by the time it will be ready, about an hour or 2, if kalau tertinggal tak hantar note, surgery will either be concluded or proceed with epidural section. Ada hari tu, I dah jalan-jalan satu USM. Tiba-tiba pukul 5, ada lah lymph node. Okay lah, baliklah masuk lah. Never mind, that's a deal kan. So, okay, what's new? ICG, fluorescence method is simple, reliable, and this is in Malaysia, Sungai Buloh ke Selayang, not sure. Miss Suraya and Miss Juliana, as well as Prof. Sharon. Conclusion is ICG method is simple, reliable, and safe. Moreover, it demonstrates high sentinel lymph node dissection rate with a low false negative rate and does not require a special instrument for isotope use. Actually, it does need a special instrument, fluorescence, but with the system here. So maybe we'll try and error. Okay, and this is the weather. This is the combination of ICG and blue dye. The conclusion is the efficiency and sensitivity of sentinel lymph node biopsy can be improved by combining ICG with blue dye. Like people say, dual method is better. So whatever dual that you use is probably better than just single method. Okay, there's a bit more. How do you manage if the sentinel node biopsy you're positive? Standard approach for patient presenting with the clinically negative. Based on the Z11 trial, completion of epidural section is not indicated when patient will be receiving post-white local radiation therapy and appropriate systemic adjuvant therapy. Katalah dia tak buat apa-apa lepas tu, cannot lah. Kena buat epidural section. For women, however, some of the criteria are lain sikit lah dekat Z11 tadi. Anyway, women presenting with tumor larger than 5 cm with 1 or 2 positive nodes, the panel endorsed omitting AD following sentinel node provided that the regional nodal irradiation including the axilla was planned as a component of local regional treatment. Sebab tu, kalau white local is better sebab memang the breast akan diberi radiation. So saya langsung kenalah dekat axilla. But now with this they prescribe the axilla sekali radiation. Okay. Okay. So now they advise kalau positif either completion or regional radiation therapy. You can choose. But with the advent of frozen section, we will usually proceed lah. Okay, the epidural section after mastectomy could be omitted in a patient with 1 or 2, provided that you plan for this. No radiation. If tak ada radiation plan, you recommend completion. Macam pusing-pusing kat situ jugalah. So meaning kalau positif sentinel node, you can either epidural section ataupun radiation. Kalau yang tak plan nak buat radiation tu complete. Because the extra cell yang ada ni will be eradicated by the radiation later. Okay, after new adjuvant systemic therapy. So nowadays kita memang commonly bagi, especially with a lot of new paradigm shift now with HER2 positive and TNBC are being given chemotherapy prior to operation, even though it's small. So, panel considered who presented with a clinically positive, as we know, clinical, and received systemic therapy, downstage axilla to clearly negative, allow for sentinel node biopsy instead of axilla section, provided that 3 or more sentinel were identified and all were negative. Maksudnya kalau lepas buat chemotherapy daripada positif, clinical and ultrasound or imaging jadi negatif, you can proceed provided you kena keluarkan 3 lah. Ya, keluarkan 1 je kan. 3 semua negatif. Then okay. Or nowadays dia targeted approach, maksudnya you clip the axilla before giving. Clip tu letak marker, tanda kan, letak stapler ke apa ke, bukan stapler, ada this marker, biological marker where they put in. It will stay and become radio opaque, so for detection later, sebab by the time dah tak ada lesion, you can detect that marker. But then after that you have to remove with hook wire jugalah kan, sebab mana tahu yang mana satu kita mark kan. Okay, this is the paper I quote, walaupun dah 2019 kan. Women with residual nodal disease after NST, tak payahlah buat sentinel, buat terus. Ataupun patient ni ada N2. N2 means T1, sorry T2, sorry N1, N2 kan. N2 is fixed and method ipsilateral tumor. Okay dah last. Patient who present with okay, yang satu lagi ni setting of microstatic residual cancer at sentinel biopsy after NST, even micromets. Kalau micromets primary tumor tak pernah buat NST lagi, tak apa, but not in post neoadjuvant. Okay, thank you for your kind attention. I pun ada juga pantun. Anak kucing namanya Oyen, makan kibble setiada jenama, harap ilmu diterima hadirin, yang baik itu dari yang esa. Okay, terima kasih untuk your attention. Yang tidur pun I nampak juga, tapi I won't call any of your names, don't worry. This is my alma mater. Masa ni I dah dengar dah, my surgeon buat sentinel node biopsy. Dia kata, okay now we tunggu frozen. I cakap, berapa lama tunggu frozen, Mr. Redmond? Dia kata 2 hari. Saya, I don't understand Irish jokes kan agaknya. Dia pun nampak I macam betul-betul terkejut. Dia kata, no lah, 1 hour siap, dia kata. So that's what, dululah. Okay, terima kasih.
Okay, thank you Ms. Maya for the informative presentation. Any questions to our speaker?
Tak ada lah kan, cuma tak apalah, take home message. Early, lah soalan pula. Boleh.
Ada lymph node, sentinel lymph node yang dihantar 1, ada yang dihantar sampai 4. Macam mana kita tentukan ke-4 tu adalah sentinel, dan ada juga kes yang hanya 1. Macam mana Miss Maya pilih node tu, ada yang hantar 1, kadang 4, macam mana?
Okay, actually macam tadi lah, kita depends on the cavity count dan juga blue color of the node. Kadang-kadang 1 tu aja count yang ada. Cari lagi semua dah tak ada dah. So itu je lah yang kita hantar. Dan kadang-kadang tu dah keluar 3 pun ada lagi. Ataupun kadang-kadang kita nampak lagi blue. Ada juga yang kadang-kadang kita dah hantar dah sentinel tak ada lagi. No more count, no more. Kalau ni you have these 2 lah.
Lymph node yang besar tu ke, when you say 900 tu, what do you mean by that? Count the dots ke macam mana?
Okay, count tu pakai kita punya apa nama tadi yang bunyi tadi kan?
Machine.
Yang bunyi tu machine. Initial count was apa dia panggil? It's a gamma Geiger counter. Count activity. lymph node ada with high radiation count. So if it's out, the surrounding basal count will be actually zero lah kan. However, sebab dia ada macam dah sel tu dah merata-rata around that area, the count that is yang tinggal tu must be less than 10% of the initial count. Katalah the count on the skin or on the highest number that you count tadi 50. And then bila you buat tu sekarang ni tinggal 300 macam tu. 30 ke, boleh lah. I mean you can close the operation wound lah sebab dah tak ada dah the radiated node radiation infested node lah. That's how kalau guna tu lah. Sebab tu find it easier lah to have a dual method sebab dia bunyi. Kalau yang colour biru tu bila cari-cari channel tu putus. So lepas tu jalan pun sesat. But it's cheaper lah actually kalau boleh buat blue dye sahaja. Tapi yalah, we have already the ni and it's noted that actually the procedure is very expensive. We charge around 900 for the ni lah for the radio isolation.
Thank you again, Ms. Maya, for the lecture. We have to conclude the session now to allow our next session. Dengan ini saya mempersilakan Dr. Norazlina Matnawi. Beliau menyandang jawatan sebagai Ketua Jabatan Perubatan Nuklear, Radioterapi dan Onkologi sebagai pensyarah perubatan dan pakar perubatan nuklear di jabatan yang sama. Our next speaker needs no introduction. Please welcome Dr. Norazlina Matnawi, who will be speaking on a topic entitled Hot and Blue, Role of Sentinel Lymphoscintigraphy and Gamma Probe. For background, she is the current head of department for the Department of Nuclear Medicine, Radiotherapy and Oncology, and also serves as a medical lecturer and nuclear medicine specialist at the same department. Her field of interest are nuclear imaging and theranostics. The audience is eagerly anticipating your presentation. Please take the stage.
Okay, Assalamualaikum and very good morning to everyone. So, I am Dr. Norazlina Matnawi. I'm from Nuclear Medicine Department, School of Medical Sciences, USM. So, my title of my presentation is Hot and Blue and Role of Sentinel Lymphoscintigraphy and Gamma Probe. Okay, so basically my talk, the outline of my presentation, I will cover the definition of the sentinel nodes, how to identify the sentinel nodes, what is the indication of the sentinel nodes mapping and biopsy, who are the personnel involved, and role of sentinel lymphoscintigraphy and gamma probe, and why is it so important to identify the sentinel node. And I'm sharing 2 interesting cases, and also I'm sharing our journey experience towards a new service creation in Hospital USM. Okay, so to the event, we heard a lot about sentinel lymph node. So what is a sentinel lymph node? It's just a repetitive, I think. The sentinel lymph node is defined as the first lymph node to which cancer cells are most likely to spread from a primary tumor. Sometimes they can be more than one sentinel lymph node. If we can see here is this is the cancer or tumor, right? This is the cancer or tumor, and then the first node here, this one we call as the sentinel node, sentinel lymph node. And from the image, what we call the scintigraphy image, the faint uptake here is the sentinel node. Of course, the intense uptake here is the tumor itself or at the adjacent site. And this is the real sentinel node. Means it's because the surgeon inject the blue dye, so it appear blue. Is generally defined as follows. Can be defined as a node close to the primary lesion. Sentinel node also can define as the node with a radioactive channels leading to it, or could be defined as the node with the highest count rate on lymphoscintigraphy imaging and probe counting. Or sentinel node can be defined as the first node visible on lymphoscintigraphy imaging, or blue dye on dye injection technique, or some is a node with a blue channel leading to it. So kat sini we can see a lot of variable definition of the sentinel nodes. Okay, so basically how we going to identify the sentinel nodes? Actually there are few methods. So I listed here 3 methods. The former method is through the intraoperative blue dye. This one Miss Maya presented earlier regarding the inject the blue dye in the operation theatre, right? That one we call the intraoperative blue dye. The second method is this is Sentinel lymphoscintigraphy and gamma probe. Basically is a radioisotope tracer mapping preoperatively done in the nuclear medicine department. And also the third method is combining the blue dye with radioisotope method. That one we call as a dual tracer technique method. This one, this technique was found to yield a superior method and is considered as the gold standard in many guidelines. Okay, so as we can see here is a same picture, right? Miss Maya punya slide. We inject the radioactive substance or dye at the pre-tumoral, or sometimes we inject at the pre-areolar region, and then we identify where is it the sentinel node, and of course we use the gamma probe because gamma probe can detect the count of the radiation. And the surgeon, the next day the surgeon will excise at the surgical marking and remove the sentinel node. Okay, so basically the sentinel lymph node mapping and biopsy is highly reliable method for identifying metastatic and micrometastatic disease in regional lymphatic nodes. Okay, so the combination of radiocolloid injection and blue dye injection immediately before surgery give the highest sensitivity and specificity of the technique. However, some studies they found that sentinel lymph node biopsy with radioactive tracer alone is successful. And there was a meta-analysis. They found that mapping sentinel lymph node location with methylene blue alone result in acceptable identification rate but an excessive false negative rate. And newest method is they use the near infrared fluorescent imaging using indocyanine green. We don't have here. Okay, so what is the indication of the sentinel lymph node mapping and biopsy? Again, the repetition from the Miss Maya punya slide. And this sentinel lymphoscintigraph, this sentinel lymph node mapping actually is indicated for T1 and T2 stage invasive breast cancer. Basically, is indicated for early case of breast cancer patient. Also, this procedure is indicated for high-risk microinvasive ductal carcinoma in situ, and sometimes can be used in T3 tumor. We can use this method provided there is no evidence of metastasis. Basically, we followed the guideline of lymphoscintigraphy and sentinel lymph node localization in breast cancer in 2013 EANM and SNMM guideline. Okay, who are the person involved? The sentinel lymph node mapping and biopsy basically involve 3 main shooting locations. Involve the nuclear medicine department, involve the surgery or OT, and also involve our beloved pathology team. Actually, this picture I got from the AP Dr. Wan Faizia. I think I might think dia pun ada gambar yang sama after this because this picture I got from her slide. And I love this picture because she said precious nuclear team here means nuclear team too very berharga, and maybe she is very acknowledged, so that's why she keep mention precious nuclear medicine team, and of course our happy-go-lucky surgeon lah. Okay, so I go to the Sentinel Lymphoscintigraphy. So scintigraphy means it's a scanning. So, some might call as the Sentinel lymph node mapping, some call radioisotope pressure mapping, and some might call as a lymphoscintigraphy. Actually, it's a benda yang sama. And this hybrid imaging to provide functional and anatomical information because we have the spec and also the CT component. And imaging technique, this is used to identify the lymph drainage basin, can be determine the number of the sentinel node, can differentiate this sentinel node from the subsequent nodes, and it can be used to locate the sentinel node in an unexpected location. And of course, this sentinel lymphoscintigraphy is used to mark the sentinel node over the skin for biopsy. And this sentinel node mapping is rapidly becoming an alternative staging procedure for the axilla in managing early breast cancer, and is the staging modality of choice because the sentinel lymphoscintigraphy allow the surgeon to easily identify and biopsy a sentinel lymph nodes. And again, this procedure has gained importance as the standard of care for early stage breast cancer patients with negative axillary lymph nodes. Okay, so where is the role of nuclear medicine? Basically, we act at the pre-operative procedure lah. We involve the preparation of radiopharmaceutical, injection of the tracer, imaging and reporting of the sentinel lymphoscintigraphy, and also marking procedure of the sentinel node. Usually, this one will be done at the nuclear medicine department 1 day before the surgery. Okay, so preparation of radiopharmaceuticals, we use the technetium 99M radiopharmaceutical. It could be technetium 99M antimony trisulfate, technetium 99M nanocolloid, which used here is technetium 99M nanocolloid. It can be used technetium 99M sulfur colloid or technetium 99M timanosep. This preparation of radiopharmaceutical basically done by our radiopharmacists in nuclear medicine department. Basically, they elute the technetium 99M from the generator and tag with the pharmaceutical, which is nanocolloid. That's why we call the technetium 99M nanocolloid. Okay, so for the radio tracer injection method, basically injection of radio tracer done by specialist or medical officer via aseptic technique and patient in supine position. And injection can be divided into superficial and deep method. And superficial technique include intradermal, subcutaneous, subareolar, and periareolar region. And deep technique include pre-tumoral or intratumoral injection. Here we use the periareolar injection intradermally. We practice the injection what we call the intradermal preareolarly. Okay, so this is the intradermal injection technique. As I mentioned earlier, many experts contend that this method offers the best result. We make injection 24 hours before the surgery, and we use the appropriate technetium 99 label radiopharmaceutical, and we do not delay mapping more than 15 hours after injection of technetium 99 label radiopharmaceutical, and the injection is made in the skin overlying the tumor, and the needle is inserted at an acute angle into the skin, and the patient is asked to massage over the injection site with dry cotton, and this massage should continue for 1 to 2 minutes. Okay, could be other injection technique, could be pre-tumoral or intratumoral injection technique. For the pre-tumoral injection technique, basically the injection is made deeper into the breast parenchyma around the mass. Usually we do the 4 injection around the tumor. It could be injection made superior, inferior, lateral, and medial to the mass. For the intratumoral injection technique, some authors advocated injection inside the tumor. They are concerned about the tumor spread, especially along the needle tract. and they use only the small amount of radiopharmaceutical injected into the center of the tumor. Okay, for the imaging process, basically we perform in two phases, which is the dynamic phase and also the delayed imaging. Dynamic phase take time around 15 to 20 minutes to visualize and identify the first drainage node. And for the delayed imaging, used for identification of the sentinel node and lymph node retention. And of course, we use our SPECT-CT imaging for anatomical correlation. And the shielding of the injection site is usually not needed. And this is, I think the picture is around taken around 2018, right? Our first case in HUSM. Okay, for the marking procedure, the location of the sentinel node basically identify on real-time imaging using the technetium-99m marker source and confirm with gamma probe. Once a sentinel node is identified, a radioactive marker is moved over skin while the patient is under the gamma camera detector, keeping the sentinel node in the field of view. And with real-time imaging mode, the marker is moved until the two source coincide. This area is marked with waterproof ink. And the patient must be imaged in the same position used for surgery so that there is no shift when the sentinel node is marked on the skin. And the skin mark is confirmed to actually overlay the hottest node by placing the probe tip over the area and moving it to the surrounding area. And the hottest area is identified by the pitch of the audible signal and the count on the digital display. So this is the basically our old gamma probe, and we use the gamma probe during the marking procedure. Okay, for the reporting processes, the above one is our what we call is static images, and then the below one is the SPECT-CT images. Usually we report what is the increased uptake at the or level 1 or level 2 axillary region, and usually we proceed with the SPECT-CT to further localize where is the sentinel nodes. Okay, so for the axillary node are seen in almost all patients, but the appearance of the node can take several patterns as follows. It could be only one sentinel node with or without a visible lymphatic duct, no second tier node. It could be one sentinel and one or more second tier node, or it could be simultaneous appearance of two nodes with same uptake intensity, and a node closer to the injection site that appear later than other more distant nodes. And two differentiation of the sentinel node from the second tier node can be made by the following: the presence of a lymphatic channel leading to the sentinel nodes, the sequence of appearance, the sentinel node will appear first, and the intensity of uptake. The sentinel node has more activity and intense. Okay, each and every single of modalities, it has dia ada kelebihan dia ada weakness dia. And for this lymphoscintigraphy, of course, they have a false positive and they have a false negative result. The false positive result, it can be caused by contamination of the skin or residual activity from another nuclear medicine procedure done recently. A false negative result, it may be caused by a low radiopharmaceutical dose, or because of the poor radiopharmaceutical quality, insufficient radiocolloid particle, imaging time that is too early or too late, advanced patient aid, or tumor replacement of the nodes. Okay, so finish about the sentinel lymphoscintigraphy. So as I mentioned earlier, sentinel lymphoscintigraphy done one day before the OT procedure. After we finish report and we finish mark where is the sentinel node, we pass patient to the surgeon, right? And this is intraoperative procedure mentioned earlier by Miss Maya. They inject the what we call the methylene blue dye, and also they did 5 minutes before the surgical incision. Okay, so imagine the sentinel nodes will allow the surgeon to have an idea of where to explore to retrieve the sentinel nodes. Okay, Okay, this is where is the role of gamma probe. Basically, the addition of this radio guidance using gamma probe is the true strength of the technique, because the complete excision can be confirmed by counting the area after removing the purported sentinel node to see if the count have fallen the background level. And the probe also guide the surgeon into the right direction and allow removal of invisible non-blue node that are recognizable due to their radioactive signature. And once the node is exposed, the probe is applied to it again to ensure that this has a high count rate. This is what we call hot. And if a blue dye is used and the same node is colored, this corroborate the probe data. This one we call as a blue. And once the node is removed, it is placed on the probe surface to confirm the count. And the probe is reapplied to the surgical field to confirm that the radioactive node has been removed. If all the radioactive node has been removed, the activity in the surgical bed should fall to 10% of the most active node. Okay, this one I think I answer the Dr. Faiziah punya soalan just now lah. The role of gamma probe in the operation theatre. And after that, they pass the specimen of the sentinel node to the pathology department, and this frozen section and histopathological examination will be done by our histopathologist. Okay, so why is it so important to locate the sentinel node? As we talk about the sentinel node. Sentinel node is the first node to receive the metastatic deposit in a malignancy, and we know that the lymph nodes are the most common location for metastasis, with a strong correlation between metastasis in the lymphatic system and prognosis. If the sentinel node is free or negative of metastasis, subsequent nodes are also likely to be free of the disease. It is likely that the neoplasm is still within the location of the tumor. This means that if sentinel node is negative, so we expect the subsequent node to pun negative. So that in this case, the surgeon will not proceed with the axillary lymph node dissection. If the sentinel node is positive for metastatic disease, of course, this one, the surgeon will proceed with the axillary lymph node dissection. And this accurate lymph node staging is essential for the prognosis and treatment in patients with breast cancer. Okay, so what happen if patient having the what we call the axillary lymph node dissection, the complete axillary lymph node dissection? The complication yang usually occur is lymph edema. Means patient akan develop lymph edema after the complete clearance of the axillary node. This one yang kita tak nak lah basically. So this lymph edema, they reported that if the patient undergo the lymph node biopsy, the risk is to be in the range of 5 to 17%. It's different contrast with the if a woman having the axillary lymph node dissection, the risk of lymph edema will occur around 20 to 30% lah. Okay, so given the high prevalence of breast cancer worldwide, the possibility of avoiding axillary clearance surgery in a significant number of patients makes this an extremely valuable procedure. Okay, this slide, I'm just sharing one case. Actually, it's interesting because we got Paget disease basically. So this is the 53-year-old female presented with nipple discharge and excoriation, diagnosed with left high-grade ductal carcinoma in situ with Paget disease of the nipple. And this patient underwent the last mastectomy and also the sentinel lymph node biopsy. But the sentinel lymph node negative for malignancy. Basically, this patient was treated with radiotherapy and also tablet anastrozole. And then this one, second interesting cases because we did the sentinel lymph node mapping and biopsy in male breast cancer, which is like rare for male to have the breast cancer, right? And this case basically is a 67-year-old male with encapsulated papillary carcinoma with invasive breast carcinoma, and he underwent the rare mastectomy and also the sentinel lymph node biopsy. And this sentinel lymph node negative for malignancy, this patient was subject for adjuvant chemotherapy and also the tamoxifen. Okay, so what is the other indication of the sentinel lymph node mapping and biopsy? For today's talk, we heard about the role of this procedure breast cancer, but basically it's also indicated for other malignancies such as malignant melanoma, head and neck thyroid cancer, lung cancer, gastric cancer, penile cancer, and also the gynecological malignancy lah. Okay, so sharing our journey toward service creation in HUSM. When we call a journey, of course, I'm not alone. I collaborate with the surgery and also the pathology department lah. Initially, I start with the short-term grant after I finish my MMed student. So I apply the first grant, which is PET CT, blue dye, and also gamma probe. And this grant I received around 30,000 K in 2018. I think this is our old gamma probe plus actually was found by our Miss Maya, the old gamma probe, and nobody guna pun sebelum tu. So we our first experience in 2018 lah. So gambar muda-muda 2018. Okay, so this is the number of cases. Starting 2018, we start with our new first patient, one only, and then 2019, 2 patients, 2020, 6 patients, 2021, 4 patients, 2022, 2 patients, 2023, 3 patients, and this year we just done 1 patient for this kind of procedure. See, for the challenges, macam surgery, Miss Maya explained about their challenges, but for us, of course, we have challenges when we want to start any new service. Of course, kita ada challenge, but we take the challenge, and basically the challenges are to set up one case in 3 locations simultaneously is quite tough. Basically, the surgeon contact nuclear contact pathologist, and it's a frozen section means kita kena buat macam tergesa-gesa. That's why I think it's very challenging lah, because apart from our clinical service, we have to entertain our student, and also ada JD lah, right? So, and in Kelantan, not all patients agree for this sentinel lymph node biopsy, and most of our patients, they come at late stage of the disease. So, as I mentioned earlier, this procedure is indicated for only early case of breast cancer. And also the fourth one is the challenges is when we try to convince all the staff about radiation safety. Basically, it's not in the nuclear medicine department lah. Basically, at the surgery or pathology department. We try to convince that this is the safe procedure, and it's quite tough because first experience here. Okay, so for the output of the journey, basically we propose one standard operative procedure for new service in HUSM. This one we sent for copyright in 2019, and of course we presented at the ASCOMOS conference 2019. We presented a poster, and also we published one paper. We mentioned about we report of 2 early stage breast cancer, sharing the experience of dual tracer and PET CT mapping for sentinel node biopsy. We published in Proceeding of Singapore Healthcare Journal. And of course, for this study, we also get one external grant from the company HNA Medical Supply that sponsor our event today lah. Okay, the precious moment is actually when we get new gamma probe. last year. It's very precious because we can be from the old gamma probe yang dah ada plaster, we get the new gamma probe. That is the most exciting moment lah for us. Okay, I think that's all from me. So with that, I thank you. I open for the question.
Any questions to Dr. Norazlina?
Congratulations, Dr. Norazlina, on organizing this event. My question is, we do receive patient with radio tracer being injected coming to our department for hook wire localization. So my question is, how is the radiation being how the radiation is affecting the staff handling the patient?
Okay, thank you, Dr. Lau. Actually, this question saya rasa bagus Puan Iliana kita yang jawab. Kita ada Radiation Safety Officer punya talk jugalah at the end of the session. But I give some brief lah because we are using the technetium-based radiopharmaceutical. Actually, the half-life is 6 hours only. And actually by 1 hour tu, the almost of the radiation dose is disappear from our body. So it's a very safe lah. So I think no need a special special shielding or whatever what we call the radiation shielding. We don't need that kind of radiation method lah maksudnya. That one I think doktor pula mana Puan Iliana akan present that part. Okay. So
take the concept of radioactive iodine you use for PTC kan. I'm thinking about it instead of so can we can save the surgeon from doing the axillary clearance. You just inject the dye and kill the tumor cell wherever in the lymph node and the same principle like radioiodine. Tak tahu lah. Is there any study being done now?
Okay, thank you, Dr. Faiz. So for this imaging procedure, we use the technetium-99m nanocolloid. So technetium-90m basically is only have gamma emission. It doesn't have the beta properties. If you want to treat some cancer cell, it might have the beta properties. This technetium-99m only have the gamma properties. It's only used for the imaging purpose lah. It's not for the treatment. It differs from the iodine-131. Iodine-131, it has the gamma emission and also the beta properties. The beta properties one is that we can treat the cancer cells. But for the technetium-99m nanocolloid, it's just having the gamma rays. So memang tak boleh treat. It's not used for treatment. It's just for imaging purpose. Okay.
Okay, we thank you for the excellent presentation. Hadirin yang dihormati, saya menjemput penceramah seterusnya, Profesor Madya Dr. Wan Faizia Wan Abdul Rahman untuk naik ke atas pentas bagi menyampaikan syarahan beliau. Beliau merupakan pensyarah perubatan dan pakar perunding patologi di Jabatan Patologi Hospital USM. Let's give a warm welcome to Associate Professor Dr. Wan Faizia Wan Abdul Rahman, who will be enlightening us on Sentinel Lymph node biopsy frozen section. Is it truly a nightmare for pathologists? Her current research interests are mainly in the prevention, early detection, biomarker discovery and personalized oncology of breast cancer. Please take the stage.
Oh ni. Ini
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, our good-looking Mr. MC today. Thank you for your kind introduction. Thank you to organizing committee for inviting me, and thank you to all participants today for and from various departments. Thank you for coming here, and of course, I believe that half-day seminar today very benefit to everyone. At least can give enhance certain knowledge and also some perception. All right. So as a pathologist, you know, we are so-called lab-based clinician. We work behind the stage actually. We work behind the stage. What we can do, to tell you the truth, we convey everything, our opinion, in the form of the report, pathology report. And actually, only 70% we can convert it into the pathology report. The rest, maybe around 30%, still we keep within us. Okay, so it's good to have such today's seminar where we can convey something that we never conveyed before in the pathology report, and we can share something from our perspective of view. All right. The title given by kita punya committee member, Dr. Nazrina, she asked me to talk about is it truly the nightmare for pathologists? Because I told her, yeah, this is a new thing and we need to get agree from all the pathologists because this is something quite difficult for us. Yeah, you know that in all diagnostic, before we give a diagnosis, all the cases, not all, most of the cases are already the nightmare for pathologists because before we give diagnosis, it keep coming to us. Walaupun masa nak tidur, dalam mimpi pun termimpi lagi, betul ke tak diagnosis yang dibuat, betul ke tak diagnosis yang dibuat. Apatah lagi for the frozen section where we have to give a diagnosis within 1 hour with a full of stress, pressure and everything. And that's why to reduce the nightmare, to increase the confidence level, that's why we need to prepare in terms of mental, in terms of what support from the team member. This is what we always do. So for the pathology part, what the POV, I always see this POV in TikTok and everything. I don't know, but something like what we know, we think that the pathology just easy for us, actually something easy. They only expect from us whether positive or negative for malignancy. This is the POV, but the reality behind is very, all the frozen section actually are very unique, tricky, and with full of limitations, depends on the disease. So that's why we have a lot of so-called books, many books, intraoperative consultation books for us, to guide us, to give us the knowledge on how to tackle the frozen cases and to give the most accurate diagnosis during the frozen case or intraoperative consultation. So we need to prepare, need to read everything about the case. And if junior, usually kalau masa I junior dulu, memang I make sure ada senior, anything kita boleh refer. Sekarang kita dah ada beberapa expertise. Contohnya kalau saya dapat case brain, saya make sure ada yang expert on brain. Kalau saya dapat case of lymphoma, for example, saya make sure Dr. Faiz ada. So in case within 1 hour saya tak dapat nak bagi diagnosis, so saya akan boleh rujuk. This is our what we call the scenario lah dalam masa sejam tu apa yang ketakutan kami. That's why kita panggil dia adalah nightmare for pathologists. Because it's not because we understand the consequences behind from our diagnosis. For example, in sentinel lymph node biopsy, we know that if we say positive for malignancy, cancer cell positive, we know that there will be total axillary lymph node dissection will be done. So you know what the complication of that? And the most complication is lymph edema, right? Because you know lymph node, everyone know because it's just like a system of paparitan or to irrigate all the fluid in the body. Once we cut or we do something with that, so there will be swelling, edema. And then there will be a lot more complication after that, like infection, numbness, reduced range of movement, cannot move with the hand, whatever, and increase the morbidity of the patient. All right, but when we call it, we say it is negative, so surgeon will only do the wide local excision or mastectomy only. No need proceed with the axillary clearance. But the problem is, this is the reality, where we call it false positive. This is common to have false positive, where no, not false positive, but false negative yang lagi common. Okay, false positive means that we call it a positive, but actually negative. We misinterpret the cells, maybe the germinal center cells tu yang sangat nampak agresif, tapi kita ingatkan cancer cells, so kita kata positive. And then bila kita buat proper HPE, the next day dapat negative. Tapi kita dah convey sebagai positif, and then surgeon dah buang, selamat buang dah semua axillary clearance. So, you know what this is the things that menyebabkan kita rasa takut, rasa besarnya tanggungjawab nak bagi diagnosis that will implicate the patient, life, dia punya life semua kan. And then, let's say kalau kita bagi, we give a diagnosis a negative, but actually positive. What happened? We call it false negative. So it can cause the cancer understaging and increase risk cancer recurrence, because bila kita cakap negatif, tak buat axillary clearance kan. So there will be risk for the recurrence. Okay, so everyone know about the sentinel lymph node, what is sentinel, but by right it should be the standard care. Standard care for the stage 1 and stage 2. By right kalau standard care ni semua tempat kena buat lah. Semua hospital kena buat. Tapi it's not happen like that. Not all the center willing to do it. Why? Because not everyone have a teamwork like us like this. Not all the team have a confidence. Not all hospital ada expertise yang memang boleh buat benda macam ni. So, and then, walaupun kita ada kepakaran, kemahiran, ada facility, but only selected cases only we do for the sentinel lymph node, which is usually these cases we select, we decide during the multidisciplinary team meeting. So by right, for each cancer patient, we need to do meeting to decide on what further management should be done. All right, and then this is one of the management for the patient, which is need to be decided by the team, the multidisciplinary meeting during the meeting, right? So why? Because not all cases we can proceed with sentinel lymph node. I believe that everyone know about the indication. This is the common one, the T1, the T2, and the tumor size less than 3, clinically negative axilla by palpation, and also those with the high-grade DCIS, extensive, with micro-invasion, and highly suspicious of invasion. But we have the contraindication, which is not that really contraindication, we can call it not that recommended to do sentinel lymph node biopsy because of certain reason with a high chances for the false negative, you know. which is the tumor more than T3, the clinically positive axilla, those who have been received neoadjuvant chemotherapy, because there will be increase in the false negative, about 41%. All right, and then those with multicentric tumor disease, and those with DCIS only. Pathologist tak ada cakap pun high suspicious of invasion. Radiologi pun tak ada kata. Mungkin radiologi pun agree with the DCIS. This kind of cases kita tak buat Sentinel because it found to be the very, very little to no metastatic potential. Okay, from the research. A lot of research done on this. All right, and then those with previous breast or axillary surgery, also with a high false negative rate, and pregnancy women, and also with those who with inflammatory breast cancer. Alright, okay, this picture, Dr. Noazina suka sangat picture ni. Tapi saya kekalkan dalam slide ini. Dulu saya bagi masa CPC, tapi saya dah edit untuk surgical team dengan pathology saya dah edit. Tapi untuk nuclear team kekal precious. You know, very precious. All the technology is precious, including you all. You all, your department with the technology bring to us to help us in doing this. This is a very, very precious thing for me. All right. So the rest, you know already. The happy-go-lucky, ready to cut surgeon, aroused surgeon, and the anxious pathology team. This is today what I'm going to elaborate on the what behind the anxious of pathology team in this Sentinel Lymph node, because you know for the third location, which is the pathology, we need to settle within 1 hour, and then you know it involves all people in the lab, not only pathologists. Although we keep talking responsible for pathologists, but the diagnosis the pathologist has make a diagnosis very, very highly dependent to the technical staff. How good they are doing the sectioning, how good they are doing the rapid staining. If they give us the good section with good morphology, good everything, so we can give a good diagnosis, convey the good diagnosis to surgeon. Inshallah, almost accurate the diagnosis. But if the things section pun tak bagus, everything, so very, very frustrating lah, dan tak boleh membantu lah untuk proses diagnosis. Alright, so before we talk about the frozen section, everyone should know at least the basic idea on how the tissue is processed. For the HPE, I mean the routine punya histopathology, ya, barulah kita boleh faham what behind the frozen section. Okay, mungkin ada yang tertanya-tanya, kalau HPE itu paling cepat pun 3 hari baru boleh siap, macam mana frozen section boleh siap dalam masa 1 jam? Sebenarnya patologi ni boleh je cepatkan tisu saja, dia nak simpan sampai seminggu. Mungkin ada yang berpendapat macam tu sebab dia tak faham tentang proses macam mana tisu tu diproses. Kalau dalam rutin punya HPE, kita tahu sampel yang kita dapat yang telah dimasukkan dalam formalin, di mana kalau telah masukkan formalin, operation hari ini hantar kepada kami tak boleh proses. Sebab walaupun dah dimasukkan formalin, dia sekurang-kurangnya 6 atau 7 jam. Biasanya kita keep overnight. The next day baru kita buat, because allow the tissue to be absorbed by the formalin to maintain the structure of the tissue. Alright? So overnight kat situ. And then the next day baru proses. Lepas tu masuk dalam machine tissue processor, which is also another overnight. Dah 2 hari dah kat situ. Alright. And then the next day tu baru kita proses, masukkan dalam lilin parafin, baru kita buat sectioning, baru kita fishing, staining semua tu, baru dapat slide. Banyak sekali dapat slide dekat pathologist, bukan nak tengok kes tu je, banyak. So kenalah ikut queue, tengok tower paling tinggi, ikut nombor. Okay, so That's why paling urgent pun boleh buat dalam masa 3 hari. Alright. So apa yang jadi? What happened for frozen section? Kenapa kita boleh buat dalam masa sejam? Okay. First, because we process a fresh tissue. Kita tak masuk dalam formalin. Fresh tissue dihantar kepada kami. So what we do with that fresh tissue? This is the important of the this machine. We call it cryostat. This cryostat yang kita ada dekat lab sekarang sangat-sangat uzur, dah rasanya lebih pada 20 tahun ke? Saya punya pegawai saya ada kat sini. Kita punya HOD ada. Berapa tahun dah cryostat kita, Dr. Faiz? 15-16 tahun dah hampir. Kita dah apply lah dengan kita punya TPAI tadi, minta dia prioritikan untuk kes ni. Sebab saya difahamkan terlalu lama dah tak ada spare part. In case rosak tak akan dibaiki, tak ada dah company ataupun syarikat yang akan baiki. Doa-doa jangan rosak. Kalau rosak, stop kita punya perkhidmatan sampai kita dapat yang baru. Okey. Jadi sebab kita kerja dalam teamwork, saya mohon my team yang daripada surgery ke nuclear medicine, supportlah kita punya permohonan ni untuk dapatkan yang baru. Kan? Sebab kalau you all know, kalau tiba-tiba shutdown memang tak boleh nak buat apalah. Kena stop dulu perkhidmatan. So apa specialnya cryostat ni, di mana kita tisu yang kita dah examine tadi, fresh tissue tadi, kita masukkan ke sini, kita allow rapid freezing. Kita rapid freezing, and then kita buat sectioning guna microtome juga, tapi microtome yang berada dalam mesin cryostat ni, di mana dia suhu dia negatif 10 sampai negatif 30. Kita kena buat cold cuts kat situ. And then after that kita do the rapid staining by H&E. So it took about the process ni saja lebih kurang dalam 15 minit paling cepat kita boleh buat, and then hantar ke pathologist untuk baca slide. So basically kalau satu tisu memang boleh dapat within 1 hour lah. Tapi kalau banyak tisu kena increase lah the time. Alright. So what the challenges and limitation for the Sentinel Lymph node biopsy? Frozen section. Problem kat sini frozen section. You know, bila kita paksa dia mengeras, kita paksa dia freezing. Bukan secara gentle, secara lumrah, usual, macam HBE. Kita paksa. Macam-macam lah terjadi bila kita paksa. Okay? That will cause the poor section quality. Especially, kita tahu lymph node, surrounding dia banyak fatty tissue. Fatty tissue never freeze. Fatty tissue never freeze. It is very soft and it causes the shattering and folding. It's very difficult to section. That's why what we do bila kita dapat notes tu, pathologist akan examine dulu. Kita akan trim. Kita akan trim all the fat tissue. Tapi kena hati-hati sangat trim, takut kena capsule. The most important area untuk kita nak examine. Itu yang penting. That's why memang betul-betul kena skill kat situ lah. And then problem with the freezing artifact lah. Kita guna solution yang untuk freeze tu, it can cause damage to the tissue structure, poor tissue morphology. Pendek kata tak samalah HPE yang kita tengok frozen dengan yang tengok HPE biasa tu. Nak buat accurate diagnosis tu taklah. That's why kita pilih certain indication sahaja untuk buat frozen. And also the drying artifact that cause the cloudy tissue morphology and bloated cells morphology. Cells tu kalau memang frozen memang nampak larger than normal cell because dia not that well preserved kan kita, because of that freezing artifact. And then problem with the Sentinel Lymph node, you know, we have a lot of germinal center cells. Kita ada lymphoid tissue, and tengah-tengah tu ada germinal center cell. Ada satu case tu dia punya germinal center cell tu sangat reaktif, besar germinal center cell tu, banyak sel yang sangat aktif dengan mitosis yang melambat-lambat. Bayangkan bila kita tengok gerun, MO kata, "Doktor, this is malignancy." Kata, "No, tengok betul-betul pattern dia. Pattern dia tu this is a pattern of germinal center." Kalau kita tengok betul-betul sel tu, kita akan kata cancer cell. Tapi kita kena tengok, study everything, morphology, the pattern dia. kalau cancer cell dia mesti datang daripada bawah kapsul, subkapsulan masuk kat situ. And then now you nampak tiba-tiba pak kat tengah. Is it possible? No. So that's why kita kata negatif. Tapi sementara nak tunggu paraffin section tu, yang the next day dapat paraffin section, saya berdebar juga. Takut MO saya tu kata betul. Takut itu adalah malignancy. Berdebar saya. Dapat tengok, oh betul, bukan malignancy. That's germinal center cells. Jadi rasa lega, satu kelegaan. Sebelum tu memang duk fikir-fikir lah, macam-macam duk fikir kan, takut betul malignant cell. Okay, and then poor rapid staining pun akan memberi masalah kepada tissue. That's related to the poor tissue section lah. Right, this is the freezing artifact kita. Contohnya tissue shattering of the tissue because it happened due to blocks to too cold or tissue with the high water content. Yeah, just imagine that we try to cut the ice and we freeze there and then we cut. This is what happened lah. Problem lah, nak tengok morphology pun susah. This is our case. Tissue shattering is happen like this, and the severe most problem. When we have this kind of morphology, we call it ice crystal artifact. This is due to slow freezing during the frozen section procedure to slow freezing. That's why banyak center yang sentiasa bertukar-tukar dia punya freezing medium tu. Ada yang guna liquid nitrogen lah, ada guna macam-macam. Kita guna yang ready to use yang tu. Sebab dia nak make sure dia fast freezing. Bila slow freezing, this is what happen. Memang tak nampak lah morphology. Memang ketut dahi lah kami macam mana nak buat ni. Okay, and then wavy line shatter lah. Dia macam biasa terjadi pada mesen yang uzo, yang lama. Mikrotom dia tu longgar. Bukan mikrotom longgar, tempat letak tisu tu longgar. Macam gerak-gerak. So inilah jadi. Ada tebal, ada nipis. Kita call it shattering. Alright? Ini adalah cabaran yang terbesar lah untuk Sentinel, wrestling the fat in the Sentinel Lymph node biopsy frozen, because the fat will never freeze. Ini adalah masalah utama kami. Kalau kita tak boleh buang sepenuhnya fatty tissue tu, what we have to do, we try to avoid. Kita try pusing kawasan yang ada fat tu biar dia section tu last. Jangan section first. Kalau section first habis, hak lain habis rosak. Section ni semua memang hodoh, tak cantik. Alright, that's the problem. Dan kalau skillful punya technologies, dia tahulah macam mana teknik-teknik untuk tackle this problem. Okay? So this is our case lah. This is what happened. The folded frozen section tissue. This is the normal HPE. Just nak minta boleh compare kan, dia punya morphology tu berbeza. Jelas kita nampak cell malignancy. This is a malignant cells yang invade masuk dalam lymph node. Okay. So, talking about the false negative lymph node ni. False negative ni kami report sebagai negatif, tapi sebenarnya ada cancer. Yang common, kita ada dua case. Yang common disebabkan oleh micromax dengan macrometastasis kecil dengan isolated tumor cell. Tapi ada lagi kes-kes lain sebenarnya possible untuk dia positif, tapi kami report negatif. Contohnya kalau channel lymphatic channel tu dah block by the tumor emboli ataupun fibrosis, di mana tempat sentinel yang kita ambil tu channel dia dah block, tapi tumor emboli pergi tempat lain, duduk dekat lymph node lain, possible positif. Okey, mungkin dia ada dua lymphatic, dua highway, kita ambil satu highway, tapi satu highway lagi mungkin possible positif. Satu lagi yang train yang traverse lah. Dia pergi ke higher node, dia tak pergi, the sentinel yang paling dekat tak pergi. Okay, that's possible. Alright, and then the common one, the micromax dengan isolated tumor cell, because during frozen sections very difficult to see the micrometastasis. Alright, this is the recent case, this year punya case, one frozen section for sentinel lymph node. Ada one case tu, this patient, saya tak ingat umur berapa, tapi patient ni dia punya morphology, dia punya biopsy high grade, grade 3 punya tumor. Tapi size still around borderline T1 or T2, around 2 cm, around that. Tapi dia pun ER, PR negatif, HER2 possible negatif, walaupun ditulis sebagai 2+, need to confirm by FISH. Tapi bila saya tengok morphology dia, saya gerun. Sangat-sangat agresif. Sangat-sangat high grade, very bizarre looking cells. Tapi Sentinel Lymph node dia dapat 4. So semua masa frozen tu kita report sebagai negatif. Walaupun dengan reluctant yang saya nak kata negatif. Sebab alhamdulillah saya ada satu gut feeling yang saya rasa there's something wrong. Saya rasa dengan keadaan morfologi dia yang sangat ganas tu, mustahil dia tak pergi ke lymph node. Itu yang my feeling. Walaupun tisu tu adalah kecil. Bila my feeling kata macam tu, it happened when we receive the frozen paraffin section. I found the first node nampak ada tumor cells located within the capsules. Very small, which is I thought this is the isolated tumor cell, less than 0.2 millimeter. But I ordered the immunohisto and it is confirmed. I ordered the immunohisto, it is confirmed to be tumor cells. And I order for the serial sampai exhausted tissue tu. Nak buat another further immuno dah tak ada dah, exhausted dah. Order serial and kita nampak actually the tumor cells is 0.3 and which is considered micrometastasis just beneath the capsule. At the capsule and beneath the capsules, it macam early metastasis. And then I tried examining another 3 lymph nodes. Luckily, that's not there, only the first lymph node. But no problem, we report to the surgical team that micrometastasis seen by the paraffin section, not the frozen section. But no problem because still micrometastasis or isolated tumor cells, no need for the axillary clearance, but it gives another prognosis for the patient. And this is the case before. The case before last 2 years or last year, I can't remember. Actually, frozen section negative. Tapi paraffin section, we can see just beneath the capsule, there's a tumor focus here. When we go back to the frozen section, betul-betul area yang kami nak tengok ni, dia folded. Folded. Technical team masa tu, you know, during frozen, orang duk call, dah siap ke? Nak repeat pun macam terfikir, tak apalah, insyaAllah tak ada apalah kot. Macam tu, negatif. So tempat tu lah, tempat yang folded tu lah actually ada tumor cell. Bila kita buat immuno, memang betul tumor cell, which is considered as micrometastasis. So that's why I need to understand that the frozen section is not for us to find the micrometastasis or isolated tumor cell, only the macro, the big one. Kita yang tu yang kita mampu. Kalau yang isolated tumor cells, kami tak mampu. Alright. Okay, so how actually sentinel lymph node biopsy been done? Kalau ikut kita punya standard, kita tengok size of the node tu lah. Kalau more than 5 cm, whether more than 5 cm or less than 5 cm. Kalau more, kita kena serially slice. So banyaklah lagi kaset frozen yang kita kena buat, lagi lama lah pula nunggu kan. Tapi kalau by gross, kita dah nampak, kita just ambil satu representative je untuk confirm. Alright. So ini yang kita buat copyright lah. Kita ada beberapa hospital dah minta benda ni dan kita bagi yang PDF yang copyright, menunjukkan kita yang dah buat lah benda ni. Jadi benda ni kita buat awal-awal dulu sebab kita baru first nak set up benda ni kan. Jadi kena buat proper, what should be we call it SOP lah, standard operating procedure. So sebelum kita buat SOP ni, kita ambil pelbagai reference lah dan kita adopt from the reference dan kita buat yang kita sendiri. That's why kita boleh buat copyright. Di mana kita tak tiru mereka sebiji-sebiji, kita buat yang kita sendiri based on our references. Alright. So kita buat ikut kemampuan kita, bukan suka-suka kita nak buat ikut mana kemampuan kita. Ikut kita punya course. Ada center yang kaya sampai semua slide dia buat immuno, itu yang kaya lah. Lepas tu kita tengok kemampuan, kita ambil representative macam tu. InsyaAllah cover lah everything. Contohnya kalau kita ambil 4 mm, 4 mm size of the nodes tu. Kalau lymph node tu kecil, kita ambil letak satu entire. But kalau besar, kita cut into 2. Bila kita cut into 2 and then kita submit untuk section, for the each section tu dia kena ambil at least around 3 initial section lah. Yang superficial, yang medium dengan yang deeper section. At least untuk satu tu 3. Cuba bayangkan hari tu kita dapat 4 lymph node. Satu lymph node tu kita belah 2 and then kita buat section. Okey, satu lymph node tu 6. So 6 kali 4, 24 slide yang kita kena tengok. Besok macam tu. Sebab kita kena level lagi. Okay. Dan 24 slide juga lah buat rapid staining semualah. And then saya tengok teknologi saya gini. Exercise tangan. Buat cryostat tu lah. Kan? Memang kalau banyak lagi memang penat lagi lah. Ada lagi kes yang lain macam Hirschsprung ke apa sampai A, B, C, D, E, F, G, H, I, J. Tissue dia level. Memang tiring day. Very tiring day. Penat sangat-sangat. Saya pun kesian tengok dia penat sangat lah. Okay. So kalau ada yang berminat untuk tengok the flow dia actually apa dia macam apa yang kita buat untuk ni, kita boleh rujuk kepada kita punya SOP lah. Saya boleh edarkan SOP tersebut dalam bentuk PDF. Cuma dalam masa buat SOP tu kita consider juga dia punya technetium punya ni radioaktif, di mana kita nak satisfy everyone, make sure clear. You know that lab base, bukannya lab base ni takut sangat dengan radioaktif, sinaran radioaktif, tapi you know kita dah terdedah kepada banyak karsinogen. Dengan formalinnya, dengan xylinnya, dengan apa entah macam-macam karsinogen lagi kita sekitar. Nak tambah radioaktif pula lagi. That's why kita kena clear. That's why kita buat satu SOP bagi tahu yang sebenarnya tak banyak sangat pun dia punya sinaran tu. And then bila dia punya decay tu dalam masa berapa jam semua tu kan. Dan nak convince to everyone that this is safe. This is safe. So I think that's all from me. Masa pun dah habis. Terima kasih kerana sudi mendengar. Okay. Okay, alhamdulillah. You know that bila kita ada teamwork, it's a very interesting thing because everyone understand us, understanding the limitation why we are still doing the best. Assalamualaikum warahmatullahi wabarakatuh.
Alright, thank you Dr. Wan Faizia for the excellent lecture. Hadirin yang dikasihi sekalian, penceramah terakhir kita pada hari ini ialah Puan Iliana Abdul Aziz. Beliau kini berkhidmat sebagai pegawai sains di unit perubatan nuklear dan sedang mengambil ijazah sarjana dalam bidang perubatan nuklear di Pusat Pengajian Sains Perubatan USM. Our last lecture session for today will be delivered by none other than Mrs. Iliana Abdul Aziz. She is a science officer at the Nuclear Medicine Unit and is currently undergoing her master's training in nuclear medicine at the School of Medical Sciences USM. Some of her interests include clinical nuclear medicine, radiation protection and safety, as well as radioactive waste management. The title of her presentation is MI Safe? Radiation Safety in Sentinel Lymph Node and Biopsy. I welcome to you Mrs. Iliana Abdul Aziz.
Okay, terima kasih kepada pengurusi majlis. Okay, slot terakhir pada kita punya seminar hari ini iaitu berkenaan dengan radiation protection in Sentinel Lymph Node Biopsy. Saya sebelum saya perkenalkan dirilah, saya Iliana Abdul Aziz selaku pegawai sains fizik di unit perubatan nuklear, Jabatan Perubatan Nuklear, Radioterapi dan Onkologi Hospital US. Okey, so saya tahu mesti ramai tertunggu-tunggu slot saya ni kan. Okeylah. So saya rasa simple je saya punya presentation hari ni, and then takkan ambil masa yang lama lah kalau tak ada banyak soalan. Okey, so am I safe? Kalau saya tanya agak-agak selamat ke tak? Selamat kan? Okey, nanti saya tunjuk saya ada satu study case and then saya akan present lah sama ada radiation exposure yang kita terima adalah melebihi hard dose limit sebagai public figure. Okay, so this is my topic, which is I can introduce about the Sentinel Lymph Node, and then what is my primary goals, and then I can explain about the technetium-99 metastasis characteristic and also principal radiation protection and limit dose for the radiation worker and public, and my case study. Okay, so the introduction, as you know, SLNP procedure in HUSM is 2 days protocol, use of technetium-99m nanocolloid with activity range 1 until 2 MCI, and then the radioactive is injected near the tumor site. So kat sini saya nak highlight kat sini radioactive activity technetium 99M yang kita guna hanya 1 hingga 2 MCI, which is sangat, bagi saya sangat sikit lah compare dengan prosedur yang terdapat di perubatan nuklear. Contohnya sebagai boskan, biasanya kita akan inject pada patient 20 MCI. So boleh bayangkan perbezaan yang kita bagi pada patient Sentinel dengan patient bone scan. Okay, so macam biasalah, this is our team during procedure of SLNB, and also which is nuclear medicine, of course, as a radiation worker. So saya nak highlight kat sini, tim surgery dan juga tim pathology is non-radiation workers. So of course lah, mesti tertanya sama ada selamat ataupun tidak bila kita gunakan technetium tu, and berapa kita punya dedahan yang kita terima. Compare bila saya tanya pada tim radiation worker nuclear med, mesti kata alah sikit je. Tapi bila saya masuk dalam OT ke, mesti orang tanya, tak apa ke duduk kat sini dekat-dekat dengan patient ni. So mesti orang nak tahu sama ada selamat ataupun tidak. So hari ini saya akan explain lah berkenaan dengan radiation exposure bila kita melakukan Sentinel Lymph node. Okay, so this is my primary goals, which is, of course, I want all the staff protected from radiation emitted during Sentinel Lymph node biopsy procedure. So saya nak semua staff yang terlibat dalam prosedur ni, iaitu selamatlah daripada dedahan radiasi yang berbahaya. Okay, this is our guidelines. So ni adalah 2 akta yang kita gunakan bila kita bekerja dengan radioaktif lah, iaitu 1 Akta Pelaksanaan Tenaga Atom atau dikenali sebagai Akta 304, dan juga yang kedua Peraturan Perlindungan Sinaran Asas 2010. So kalau ikutkan kat sini, Akta Pelaksanaan Akta 304 ni dia more kepada pelaksanaan kita nak gunakan radioaktif tu macam mana. And then saya nak tekan kat sini, Peraturan Perlindungan Sinaran Asas ni ialah bagaimana kita nak bekerja dengan cara yang selamat bila kita expose dengan radiation. Okay, so as we know, technetium ni kita gunakan untuk kita punya prosedur Sentinel. So dekat sini macam Dr. Norina dah explain, technetium ni kita pakai 99. Technetium ni akan mempunyai half-life sebanyak 6 jam sahaja untuk dia mereput dan mengeluarkan sinaran gamma ray hanya energinya 143 kiloelectronvolt. So kalau tengok kat sini, low energy gamma ray emitted, and then half life of 6 hours only. Kita compare dengan, kalau compare dengan radioaktif lain, contohnya iodine-131 8 hari untuk dia punya half life. So kita compare pula technetium hanya 6 jam sahaja. Okay, so mesti tak faham half life tu macam mana. Okay, this is half life for 99M technetium. Kalau kita tengok, maksudnya half life ni separuh hayat. Maksudnya separuh hayat technetium tu untuk dia mereput separuh daripada aktiviti asal dia. Contohnya kalau dekat sini kita tengok aktiviti asal dia 4000 becquerel. Becquerel ni unit for activity jugalah. Biasanya kita kat sini kita pakai millicurie. Okay, so selepas 6 jam, selepas 6 jam, 6 jam kita tengok separuh hayat dia, separuh aktiviti dia sebanyak 2000 becquerel. So sampailah pada 40 jam, lebih kurang 2 hari. 2 atau 3 hari lah. Kita tengok kat sini aktiviti dia dah 0. Okay, so tak lama sebenarnya technetium berada dalam badan pesakit. Okay, so simple je. Prinsipal yang kita kena amalkan waktu kita melakukan prosedur Sentinel, kita mainkan prinsipal 1, kita mainkan dengan masa, dengan jarak dan juga shielding. Okay, so dengan masa, saya explain berkenaan dengan jarak lah. So jaraknya kita biasa gunakan inverse square law, di mana semakin dekat kita dengan sumber source technetium tu, semakin banyak dos dedahan yang kita terima. So kalau kat sini sebagai contohlah tim surgery, kita tahu kan yang kita tak bolehlah duduk 1 meter untuk buat biopsi kan. Okay, so kat sini kalau boleh sejauh yang mungkin lah, kalau boleh tak adalah, kita dekat dengan bad patient tu, dekat je and then terlalu lama kita terexpose. So kalau boleh jarak yang selamat adalah 0.3 meter. So kat situ nanti saya explain berkenaan dengan saya punya study lah. Okay, so jarak kat sini lagi satu, kalau staff nurse yang handle pesakit Sentinel ni, kalau rasa tak perlu berada dekat dengan patient tu, tak perlulah. Tak payahlah nak bersembang ke apa kan, lama-lama kat situ tak perlu. So in case kalau ada emergency ke apa, baru boleh kita dekat dengan patient. Okay, so kedua kita mainkan dengan masa. So kat sini kadar dos kali dengan masa. Contohnya kat sini patient Sentinel lah, iaitu dia akan mengeluarkan sinaran gamma ray. So kalau kita tengok kat sini, dose rate yang diterima dari jarak 1 meter contohnya lah 1 milisievert per hour. So kalau kat sini makin lama dia duduk berdekatan dengan patient, lagi banyaklah dos yang diterima. Maksudnya 1 milisievert kali dengan berapa jam duduk dengan patient, 3 jam ke, akan dapat 3 milisievert. Okay, so ini dari jarak 1 meter. Okay, lagi satu kita pakai shielding. Okay, shielding untuk gamma ray biasanya kita akan guna plumbum ataupun konkrit lah. Tapi kebiasaannya, perasan tak kalau dekat radiologi, biasanya staff akan pakai leg gown. Tapi bila prosedur Sentinel ni, saya tak cakap pun, Miss Maya pakai leg gown time buat prosedur. Kan, sebab apa? Sebab saya rasa antara 3 method principle tu, bayangkan kalau nak buat operate dah lah lama pakai dengan leg gown lagi yang berat tu, why not kita mainkan jarak dengan masa. So bila kita pakai leg gown tu biasanya ambil masa yang lama kan untuk kita buat satu prosedur tu. So situ kita tak boleh lah, kita better kita pilih masa dengan jarak. Okay. Okay, ni adalah had dos sinaran mengikut pada peraturan perlindungan sinaran, iaitu had dos tahunan bagi keseluruhan tubuh untuk berbeza ya antara pekerja sinaran, iaitu 20 milisievert per year, and then untuk orang awam 1 milisievert per year. So kat sini saya nak tekankan bagi non-worker radiation lah. Okay, so untuk staff di nuklear kita classify dia sebagai radiation worker. And then selain daripada tu, contohnya di surgery juga peto sebagai orang awam. So had dos yang perlu diterima untuk staff di surgery dan juga peto adalah mestilah bawah pada 1 milisievert per year. Okay, saya nak tunjuk satu case study saya, iaitu female patient 40 tahun, and then single injection dia kita bagi 1.6 milicurie sahaja. Okay, so within 1 until 2 MCI. Okay, kalau tengok kat sini, saya akan ambil jarak pada 1 meter. And then exposure dia sebanyak pada day 1, iaitu tim nuclear med akan dapat 0.01 milirontgen per hour. And then pada day 2, pada pagi tu, tim surgery akan menerima sebanyak 0.08 milirontgen per hour. So kat sini, saya dah rumuskan kat sini. Pada hari pertama, kita akan cucuk 1.6 MCI pada patient. And then pada hari 2, kita tahu technician tu akan decay dan dia punya aktiviti hanya 0.172 milicurie. Sangat beza. Okay. So and then daripada jarak pula, saya ambil 1 meter kat sini, 0.7 microsievert per hour. And then di OT, saya ambil jarak pada 1 meter, 0.28 microsievert per hour. Tapi perasan tak, dia ada beza kat sini. Kenapa dia tu lagi tinggi? Okay, sebabnya waktu kita pada hari kedua tu, there is less attenuation dan juga maksudnya direct reading kita terima daripada note tu. Kan hari pertama patient tu kita tak biopsi lagi kan. So akan ada attenuation scattered. Okay. So hari kedua kita dah buka, memang direct reading. Terutama pada surgeon lah. Okay, tapinya kita tengok pada reading, Biasanya saya akan ambil 0.13 meter, which is jarak antara patient dengan surgeon. Okay. Okay, kalau tengok kat sini, gambar ni, saya ambil jarak lah. Okay, saya assume 0.3. Okay, antara jarak surgeon dengan note lah. Okay, so one patient exposed 0.3 meter. Okay, pada jarak 0.3 meter, exposure yang terdedah sebanyak 3.11 microsievert per hour. Ini saya assume untuk surgeon lah. Okay, surgeon, nurses yang dekat dalam OT. Okay, so saya anggarkan Sentinel ni berada dalam patient tu, maksudnya kita expose tu maksudnya dalam masa 1 jam saja. Maksudnya lepas 1 jam tu biasanya prosedur selesai lah. Maksudnya kita dah hantar sentinel load ni, and then less lah radiation kan pada patient dan juga pada worker dekat dalam surgery tu. Okay, so kat sini saya ambil, saya anggarkan 1 kes per month. Tapi tak sampai kan, ikutkan tahunan kita 3 atau 4. Bergantung kepada bagi Dr. Azina present tadi, kes kita tak sampai pun setahun 12 cases tak sampai. So paling banyak tahun 2020 6 patient. Ini saya anggarkan saja. Contohlah kalau kita ada 1 kes tu, sebulan 1 kes. Okey, so saya akan kalikan dengan jumlah exposure ni, akan kalikan dengan setiap bulan lah 12 kes, iaitu kita terima sebanyak 32.32 microsievert. Okey. So untuk setahun, okey, mengikut pada basic safety standard tadi saya dah explain. So public hanya perlu menerima sebanyak 1 milisievert per year. So kat sini kalau saya convert dalam dalam milisievert, yang kita terima hanya 0.037 per year. Okay, which is much less than 1 milisievert per year. Okay, so it is safe for you to work with Sentinel Lymph node procedure. Okay, percaya tak? Okay, so berdasarkan reading yang exposure yang kita terima ni, kalau kita compare, so dia berada di antara, okay, diibaratkan sebagai kita atas sikit lah pada dental x-ray dengan chest x-ray, bukan berada pada paling tinggi. Okay, 0.03 per year. Okay, okay, so saya nak cerita sikit berkenaan dengan kesan deterministik. So this is determination effect, which is dia tak ada, maksudnya kat sini dia tak ada arah sambang. Sekiranya kita terexpose atas melebihi 500 milisievert, barulah kita akan dapat efek dia. So far yang kita terima hanya 0.03. Okay, so ini kesan stokastik ni juga kesan jangka masa yang panjang, maksudnya kita accumulate dose. Maksudnya dan dia tak ada loss, kita tak kontrol lah. Sepatutnya kita dapat 1 year 1 milisievert, tapi kita tak, contohnya kita ignore je. So lama-lama kita akan mengalami kesan stokastik, iaitu jangka panjang. Contohnya kanser dan juga katarak lah. Okay, of course staff yang terlibat dengan prosedur Sentinel Lymph node ni perlu memakai PPE, iaitu simple je, pakai mask, double layer glove dan juga plastic apron. So tak perlu leg gown. Okay, sebab radioaktif yang kita guna tu sangat sikit dan dose exposure kita pun sikit. Okay, so last for the summary, dose exposure for SLMB procedure is less than the dose limit for public 1 milisievert per year, and we have to practice principle of radiation protection, which is time distance shielding during Sentinel Lymph node procedure, and also wearing complete PPE. So that's all. Thank you.
Okay, thank you Mrs. Iliana for the effective presentation just now. Any questions from the audience?
Boleh? Macam mana?
Katalah patient within muda-muda lagi kan, dia ada anak kecil,
Okay.
the day before the surgery.
The day before the surgery. today sebelum.
Boleh jumpa mak dia ke ataupun kena say 7-year-old
Okey,
child?
macam kita tengok pada haflah yang saya present tadi, kalau ada budak anak-anak kecil lah, kalau boleh sebolehnya kita elakkanlah berjumpa lepas pada injection tu. So sekurang-kurangnya dalam masa 2 hari lah. 10 half life. Sebab bila kita
After surgery should be no problem lah kan, sebab it has been taken out kan.
In case kalau kata lepas pada injection nak jumpa tu tak boleh, tak digalakkan. Okey, waktu dalam ward.
Tok kena mention juga lah, katalah ada pregnant nurses ke macam mana?
Okey, pregnant nurses sebolehnya kita tak galakkan lah untuk handle prosedur. Tapi in case kalau kata tak ada staff lain lah, kita boleh dia boleh follow untuk buat prosedur, tapi kita akan bekalkan pendosimeter. So dia akan bagi direct reading. Kita tak nak bagi, kita boleh tahu terus berapa dia punya exposure. Bukan pada based on saya punya calculation tu. Okay, so dia punya exposure tu waktu melakukan prosedur tu mestilah tak lebih pada 1 milisievert. Okay, kita akan pakai pendosimeter yang biasa saya bagi pada Miss Maya. Miss Maya ingat? Tapi zero reading kan? Okay, ada lagi?
Hello, okay, terima kasih Puan Yana. Very good talk about radioactive. Saya nak tanya, ada tak faktor-faktor yang boleh menyebabkan decay, dia punya decay tu makin lambat?
Tak ada.
Tak ada.
Memang secara fizikal setiap radioaktif tu dia memang ditetapkan half-life dia berapa hari, berapa jam, berapa tahun. So that's why kita biasanya untuk diagnostik kita akan gunakan teknisium sebab half-life dia sangat rendah. And then dia akan keluarkan gamma ray sahaja. Okay.
Satu lagi, ada tak apa-apa kesan sekiranya tisu yang diinjek dengan teknisium tersebut dimasukkan ke dalam formalin? Adakah ada apa-apa reaction ataupun boleh mengubahkan dia punya decay? Tak ada?
So far tak ada. Cuma kita macam bila sampai di peto Okay, so sampel tu kalau boleh waktu kita untuk buat cross section je, waktu tu je kita dengan kita notes tu. And then kalau rasa tak perlu, kita tak payah dekat ke, kita tak payah.
Sebab untuk dalam sampel tu kita tak pernah risau tentang tersebut sebab terlalu kecil dan terlalu small. Tapi yang the main tumor tu, yang tempat the main injection, yang tu yang akan mengandungi banyak nanocolloid tersebut. Jadi apa advice untuk the main tumor tersebut? The main tumor tersebut kita akan masukkan dalam formalin, akan berada di OT dan mungkin hari tersebut juga atau keesokannya dihantar ke patologi.
Kalau keesokan dihantar dah maksudnya exposure dah decay lah. Okey.
Kalau hari yang sama tu ada lagi, kemungkinan ada lagi.
Kemungkinan memang ada.
Ada lagi.
Zero.
Okey, terima kasih.
Tapi dengan dos yang rendah.
Okey.
Okey.
Sorry, satu lagi question. Just curious sebab kita orang ni orang belakang tabir, saya pun pathologist. When you inject the patient tu, patient kan warded kan, they be in the isolated room ke ada they be sharing the whole ward?
Okay, saya rasa tak, bukan isolated room, betul? Tak kan? Cuma kena make sure waktu di dalam ward tu dia punya katil tu ada 1 meter, at least 1 meter dengan jarak katil lain, bukan berdekatan lah. Okay.
Would you advise
no need
nak bersocialize dengan patient lain?
Actually boleh, tapi dengan jarak 1 meter. So tadi nak bersembang dengan orang katil sebelah kan. So tak perlu pergi dekat katil sebelah tu, just distant. Kita main distant kat situ.
Okay. Right.
Okay.
Satu lagi saya rasa sebab semua orang ada kat sini yang terlibat dalam prosedur ni, saya rasa walaupun kita tahu within 48 hours or 2 days dia completely decay kan, dan dia punya ni pun not a powerful punya radioactive punya substance, tapi saya rasa tagging or labeling is a must for the tissue that have been injected by this technetium. So mention about that this tissue has been injected by technetium 99M, bila, time, waktu, bila semua. So kita tahu benda tu, kita know how to treat that thing. I think that's tak boleh dipandang rendah dan mudah, tak boleh dipandang mudah, dan kita rasa kena ada labeling otak tersebut.
Betul.
Okay, terima kasih.
Baik, ada soalan lagi ke? Kalau tak ada, Puan Iliana diminta untuk kekal di atas pentas bagi menerima cenderamata daripada pihak penganjur. Oleh itu saya persilakan Dr. Norazlina Maknawi dan Dr. Nurul Syamimi Suhaimi untuk naik ke atas pentas bagi sesi penyampaian cenderamata. Baik, dipersilakan Dr. Norazlina bagi menyampaikan cenderamata penghargaan kepada Puan Iliana. Seterusnya saya menjemput Profesor Madya Dr. Maya Mazwin Yahya untuk naik atas pentas bagi menerima cenderamata penghargaan. Baik, seterusnya dipersilakan Profesor Madya Dr. Wan Faizia Wan Abdul Rahman untuk naik ke atas pentas bagi menerima cenderamata penghargaan. Baik, akhir sekali saya persilakan Dr. Nurul Syamimi Suhaimi untuk menyampaikan cenderamata penghargaan kepada Dr. Norazlina Maknawi. Baiklah, nampaknya majlis kita telah sampai ke penghujungnya. Kami akan paparkan QR code untuk mata CPD sebentar saja lagi. Baik, kalau sesiapa yang nak scan QR code ni boleh scan sekarang lah. Alright. Kami mewakili pihak urus setia program merakamkan ucapan terima kasih kepada semua yang hadir pada hari ini. Diharapkan majlis ini akan menambah lagi pengetahuan berkenaan rawatan kanser payudara melalui pemetaan dan biopsi nodus limfa sentinel kepada para peserta sekalian. Sebelum bersurai, majlis memohon kerjasama semua hadirin untuk memastikan kawasan tempat duduk dibersihkan dan sebarang sampah sarap dibuang ke dalam tong sampah yang disediakan. Peserta boleh mengambil pak makanan tengah hari yang disediakan di luar auditorium. Akhir kalam, kalau ada tersilap tutur bicara, jari jemari disusun dan maaf dipinta. Sekian, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Peringatan kepada AJK, boleh ambil gambar di atas pentas sekarang? Oh, okey.